Welcome to a preview of the 2024 Infectious Disease Board Review course. I'm Henry Mazur, and with Jack Bennett, I've directed this course known as IDBR since 1994, with a faculty of over 30 nationally recognized experts from universities across the country. This course is given annually to prepare ID physicians for their initial certification, recertification, or longitudinal knowledge assessment exam. The course is an excellent review of infectious diseases, but its focus is exam preparation. Interactive questions are a key part to preparing registrants with active learning and with practice-taking ABAM-style questions. The 29th annual course includes 40 hours of lectures over 5 days. Each year, this course is taken live, virtually, or at your own pace online by over 1,000 ID physicians. The material for the course includes lectures, 500 practice questions, and special study primers, with all material available to registrants online for a year after the course is finished. For this preview, Dr. Roy Gulick, Chief of Infectious Disease at Weill Cornell Medical School in New York City, will provide a 45-minute overview of HIV recorded earlier this year for those who don't see much HIV in their practice. This is one of our Bootcamp lectures to provide basic information for those ID physicians who need a refresher before listening to the more advanced lectures during the course. Dr. Gulick?
Hi, I'm Trip Gulick. I'm the Chief of Infectious Diseases at Weill Cornell. Thanks for joining me for HIV/AIDS Bootcamp. Where are we in 2024? I have no disclosures. I am the co-chair of the US DHHS Adult and Adolescent Antiretroviral Therapy Treatment Guidelines panel, and I will be referring to the guidelines in this talk. When it comes to the ID boards, HIV accounts for 15% of the medical content, and you can see the topics here: epidemiology, pathogenesis, lab testing, a major emphasis on HIV treatment regimens and opportunistic infections, and then some mention of malignancy, other complications, and related issues. The first cases of AIDS were reported in CDC Morbidity and Mortality Weekly Report in June 1981. The headline was Pneumocystis pneumonia, Los Angeles. In the period October 80 to May 1981, 5 young men, all active homosexuals, were treated for biopsy-confirmed Pneumocystis carinii pneumonia. What was unusual was not the PCP, but the fact that the individuals had no obvious immune deficiencies. Prior cases had all been described in people with profound immunodeficiency. We now know that these were the first 5 cases of AIDS reported worldwide. So we go from 5 cases in 1981 to today, over 85 million people have been infected globally with HIV, and about half of them have died. Here we see HIV/AIDS data for the United States. In blue are the number of AIDS cases, and you can see that the peak was around the mid-1990s, and since that time, the number of cases has declined. In parallel, in green, are the number of AIDS-related deaths. This reached a peak in 1994 and 95 to become the #1 killer of young Americans, both men and women, in the United States. You note a sharp drop-off to 1997 and then a continued drop to the present day. As people don't develop AIDS and don't die from it, they live with HIV. And that's what's shown in the yellow line, the prevalence. As you can see, we have the most number of people living with HIV in the United States today. Here's a snapshot of incidence trends, that is, new cases of HIV in the United States. When you look at the age, you can see that this is a disease of young people. So most of the cases occurring between the ages of 20 and 40, though note 10% occur above the age of 50. In terms of sex, men are affected more often than women, 84% of the cases in men, about 13% in women, and transgender people are overrepresented in terms of new cases of HIV compared to the population. Most of the cases in the US occur in HIV high prevalence areas, about 78%. In terms of race and ethnicity, Blacks and Latinos are overrepresented in terms of new cases of HIV when compared to the proportions in the general population. And finally, among population groups, men who have sex with men, MSM, account for the majority of recent cases of HIV in the US, although you can see both heterosexual men and women account for a proportion of the cases. Here's a schematic of the causative agent, human immunodeficiency virus, or HIV. You can see a relatively simple structure here. The genes of the virus in the form of RNA, 2 copies, are in the core particle of the virus. And then you can see that's encased with an envelope which has specific proteins. GP is glycoprotein 41 and GP120 account for the major glycoprotein sitting on the surface of the cell. HIV was formerly called HTLV3, human T-cell leukemia virus 3, which was initially isolated by 2 groups in France and the US in 1983 and 1984. As mentioned, this is a human retrovirus with a relatively simple structure. HIV-1 is the most common type of virus worldwide. HIV-2 is a related virus, but really confined to Western Africa and countries with traditional ties to Western Africa, such as Spain, Portugal, and parts of India. There are also subtypes, also known as clades. These go by letters of the alphabet. Clade B is the most common in North America and Europe. There is a lot of data to support that this is HIV/AIDS is a zoonosis, a disease that originally occurred in animals, specifically primates, and then crossed over to man. It's estimated sometime around the year 1900. The target cell for HIV is the CD4 positive T lymphocyte, or what our patients simply call the T cell. That, of course, is an important component of the immune system, really regulating immune responses among other populations of immune cells. Question number 1, what's the current sequence of initial and confirmatory HIV diagnostic testing? Is it A, ELISA followed by Western blot, B, ELISA followed by HIV RNA, C, ELISA followed by immunoassay, D, HIV RNA followed by Western blot, E, HIV RNA followed by ELISA, or F, HIV RNA followed by immunoassay? The sequence of testing has changed in recent years, and the current sequence is a screening ELISA test followed by a specific immunoassay test. The Western blot has been abandoned, so if you see the words Western blot on a test question when it comes to HIV, that is going to be the wrong answer. So HIV testing predominantly tests for the antibody itself. This is a screening test. The ELISA tests for antibodies to both HIV-1 and HIV-2. If the ELISA is repeatedly positive, then testing proceeds to a confirmatory test. And in 2024, that is an immunoblot. Our colleagues in resource-poor countries may use a second different HIV rapid test in place of the immunoblot, but here in the US, immunoblot. There are also 20-minute oral tests that test for antibodies and even a 1-minute blood test. We can also screen directly for the virus, and the P24 antigen is one of the components of the viral structure that can be now combined with antibody testing in the latest testing modalities that we use. Viral culture is a tool really only used in research. And then, of course, we have access to HIV RNA or viral load testing. So the newer combination test for both antibodies and antigen, specifically that P24 antigen. This has decreased the window period. That's the period between exposure to HIV and when you can detect it. That used to be as long as 3 months back in the day, but now is as short as 2 weeks. So here is the testing algorithm from the CDC. We do the HIV-1/2 antigen antibody combination immunoassay. If that's negative, then we can reassure the patient that they are HIV negative. Keep up the good work, and we'll talk about prevention. If this initial immunoassay test is positive, then you go to the confirmatory test, which is the immunoassay. And that will distinguish HIV-1 and 2. So in this case, HIV-1 antibodies are positive, HIV-2 are negative, and we have now diagnosed HIV-1 infection. In a less common scenario, HIV-1 antibody negative, HIV-2 antibody positive, you've diagnosed HIV-2 infection. People can be infected with both and would have antibodies to both. If they are HIV-1 negative or indeterminate and HIV-2 negative, then you have to go to a successive test, and this would be HIV-1 NAT, which is nucleic acid testing. And most commonly, we would use the HIV RNA test in this scenario. If that is positive, so the person is antibody negative, but nucleic acid test or HIV RNA positive, you've now diagnosed acute HIV-1 infection. So you know it's acute because they haven't had time to develop the antibodies. That's why those tests are negative, but you have detected the presence of RNA. If the NAT test is negative, then what you've now diagnosed is a false positive ELISA test. And that can be seen commonly in pregnancy or autoimmune disease or other scenarios. Here is the timeline of when the various tests for HIV become positive after infection. So someone's infected at time 0, and what's graphed for you here is the viral RNA. So it does take a certain period of time, about 14 days is when you can begin to detect viral RNA. That's the first test that will become positive, and that will be detectable throughout the infection in the absence of treatment. Following viral RNA, the P24 antigen test becomes positive. And then about 3 weeks after infection, the antibody tests are now positive, so detected with ELISA. And then in the old days, we used to do Western blot detection of antibodies. So although, as mentioned, we don't do that today. And one of the reasons for it is that they are the last tests to become positive. Another reason is they're expensive. Question 2, who should not be routinely offered HIV testing? Is it a 32-year-old pregnant woman in a stable relationship, a 23-year-old sexually active monogamous gay man, a 75-year-old former injection drug user, a 10-year-old prepubescent girl, or E, all of them should be routinely offered HIV testing? And the correct answer is D, a 10-year-old prepubescent girl is not at risk for HIV. All the other people in this group should have been tested or offered HIV testing at least once in their lives. And that's in line with current recommendations from the US Preventive Services Task Force. What they recommend is to screen adolescents and adults aged 15 to 65 for HIV infection. And you can bet that advocates for adolescents and older people suggest expanding this age range as well. They also recommend screening all pregnant women. And then, as mentioned, younger adolescents and older adults who are at increased risk, meaning sexually active, should also be screened. This is a grade A recommendation that is a high certainty that the net benefit of doing it is substantial. And there's a federal rule for any grade A or B recommendation from the task force that private insurance and Medicare must pay for it without a copay. What about transmission of HIV? So what we're looking at here is what's the risk of transmission from a known positive source of HIV. And the most risky of the listed factors is blood transfusion. From a positive source to a negative person, the risk per exposure from a blood transfusion with HIV is about over 90%, so 9 in 10. Needle sharing during injection drug use, again, from a person with HIV to a negative person, is about 1 in 167 exposures. But of course, people who use needles and share needles do this repeatedly, and that increases their risk. Percutaneous needle stick, so occupational exposure to HIV, again, from someone with HIV, is about 1 in 500. And then there's sex. So receptive anal sex is the riskiest of the practices, resulting again from a positive partner to a negative partner. So receptive is the negative partner, 1 in 70 risk of transmission of HIV. Insertive anal sex, so the positive partner is inserting their penis into the anus, 1 in 1,000 risk of transmission due to insertive anal sex. Receptive penile vaginal sex would be 1 in 1,250. Insertive penile vaginal sex, 1 in 2,500. If these risks look low, of course, this is a single episode of sex and people have multiple episodes, increasing the risk. One question that comes up is oral sex. That is thought to be very low or perhaps close to zero. And then mother to child transmission. So a mother living with HIV to her developing child in utero in the absence of treatment is 1 in 4 or 23%. And I should emphasize all of these transmission numbers are in the absence of treatment of the positive partner and prevention in the negative partner, which we'll talk about later. Here's the time course of HIV infection. So someone is infected at time 0. Look at the green line first. That's viremia, the presence of HIV RNA measured in the blood. You can see that someone can have very high levels initially. The highest I've seen is 13 million copies of HIV RNA per cc of blood. That will go down for reasons that aren't crystal clear, but then be detectable throughout the infection in the absence of therapy and can reach high levels at late stages of the infection. In blue is the CD4 cell count. As you know, a normal count is about 400 cells per microliter of blood. That can dip down in acute infection. It can actually go below 200, and opportunistic infections can sometimes occur even in acute infection. But then we'll go back up to normal levels, but over the course of infection, again, in the absence of treatment, will fall. When it reaches the number 200, we now consider that the person has profound immunodeficiency and meets the case definition, according to the CDC, of AIDS. In the absence of treatment, that number can continue to fall. The lowest CD4 cell count I've seen is 0 cells per microliter. That's in blood. In purple are mucosal CD4 cells. So most of these are in the lymph nodes that line the intestinal tract. And you can see a profound decrease in the first weeks following infection. And again, in the absence of treatment, no recovery of these cells, and they can continue to fall. And then finally, in red is immune activation. So HIV is a potent activator of the immune system, leading to all kinds of immune responses, many of which will be dysfunctional. And that characterizes and correlates with end organ disease in HIV infection. I want to emphasize that the graph that you see here is in the absence of treatment. This all changes when you intervene with HIV therapy. So here is the CDC adult AIDS case definition. First coined in 1982, the term AIDS, as you know, is acquired immune deficiency syndrome. Of course, we know that a syndrome is a medical term for a disease where we don't know the underlying cause, which we didn't in 1982. Back then, it was a list of diseases and definitive diagnoses, such as opportunistic infections and cancers, and disqualifying conditions, which were cancer or other causes of immune deficiency. Again, in 83, 84, the causative agent was discovered, HIV. You might say, well, why do we still call it a syndrome? And that's just simply because the term AIDS stuck. So we still call it that today, although we know the cause. And when the virus was discovered, quickly after that, HIV antibody testing was developed. So in 1985, that was added to the case definition. So not only did a person have a qualifying disease, but also had a positive antibody test. 2 years later, presumptive diagnoses were added in the presence of a positive HIV antibody test. So you didn't need it confirmed, but presumptive. And then the latest definition goes all the way back to 1993. That's when the CD4 cell count alone, being less than 200, even without symptoms, now qualified as the CDC definition of AIDS. So what is an opportunistic infection? As you know, it's an infection caused by an organism that's capable of causing disease only in a host whose resistance is lowered. So it takes the opportunity to cause infection in the presence of immunosuppression. And that's either by other diseases, in this case AIDS, but also cancer, transplantation, autoimmune diseases, or by immunosuppressing drugs such as chemotherapy and steroid therapy. And some of the AIDS-related common opportunistic diseases are shown for you here. Bacterial ones, Mycobacterium avium complex. The most common opportunistic infection worldwide related to HIV is tuberculosis. Fungal diseases like pneumocystis, cryptococcus, histoplasma, viral diseases like CMV, parasitic diseases such as toxoplasma, and then malignancies that are AIDS-related, including Kaposi sarcoma caused by HHV8 and non-Hodgkin's lymphoma. All of these are relatively common in AIDS. We can often look at the diagnosis of an AIDS-related illness and relate it to the CD4 cell count, and the pathogenicity of the organism helps us distinguish among these different clinical possibilities. So again, what we're looking at here are CD4 cells over time in the absence of therapy. So the average time from infection to AIDS is around 10 years, again, in the absence of therapy. Above a CD4 cell count of 200 are the more aggressive pathogens shown for you here. So herpes zoster, candida, the EBV causing oral hairy leukopplakia, common causes of bacterial pneumonia such as strep pneumo, and tuberculosis. Those are the HIV-related diagnoses you would see with CD4s above 200. Once you fall below 200, the risk of pneumocystis pneumonia goes up. And actually, back in the day, this was the most common opportunistic infection in AIDS. Toxoplasmosis occurs below a CD4 count of about 100, and MAC and CMV, relatively less aggressive pathogens, only cause disease in HIV at CD4s below 50. So again, the clinical presentation and the CD4 cell count can help with your differential diagnosis. Everything I've said up till now is in the absence of antiretroviral therapy, but that, of course, has changed HIV infection. And what is our goal of ART? And that is to suppress HIV RNA, the viral load level, as low as possible for as long as possible. If we can suppress viremia, then we can preserve or even enhance immune function, which we most commonly measure with a CD4 count. And people can return to normal CD4 cell counts. And if we can do that, then we can delay the clinical progression of HIV disease. and prolong healthy survival. So when should we start antiretroviral therapy? We used to give whole lectures on this topic, but now we know, based on lots of clinical evidence, that we should offer antiretrovirals to anyone with an AIDS diagnosis or symptomatic HIV disease, and anyone asymptomatic now, regardless of CD4 cell count. And this is reflected in the two sets of US guidelines that we turn to. One is the DHHS guidelines, as I mentioned previously, available and updated frequently on the web. And the other leading brand are the International Antiviral Society USA guidelines, which are published every other year, most recently in JAMA in 2023. So we can simplify this slide now and say when to start ART, when the patient is ready, regardless of symptoms, signs, viral load, or CD4 cell count. The patient should be offered antiretroviral therapy and encouraged to take it. The guidelines also comment specifically, and ART is recommended for all persons with HIV, both to decrease their morbidity and mortality risk with an A1, the highest rating, but also to prevent the transmission of HIV to others. So not only is ART treating the person with HIV, but preventing transmission to other people. And the guidelines say initiate ART immediately or as soon as possible after HIV diagnosis. Once you're ready to start ART, the question is what to start. This is a timeline of antiretroviral agents, and you can see the very first one, AZT, approved all the way back in 1987. And we've had several drugs approved almost every year since that time, all the way to lenacapavir, the most recent drug that is now FDA approved. Total number of HIV drugs approved by the FDA is 35. And here's how they work. So to understand antiretrovirals, you need to remember the life cycle of HIV. So here is the virus, again, with its outer glycoproteins and the GP120, GP41 spikes sitting on the surface of HIV, and the inner core encapsulating the viral RNA strands. HIV specifically recognizes and binds to its target cell, the CD4 T cell, by binding GP120 to the CD4 receptor. That's the very first step in the life cycle of HIV. That induces a conformational change, which allows binding to a second receptor called the chemokine receptor, either CCR5 or CXCR4. And when those two bindings have occurred, then the viral membrane fuses with the host cell membrane. It extrudes its contents, the core particle of the virus, into the cytoplasm of the cell, which is transported into the nucleus of the cell. At the point of transportation, the RNA of the virus is reverse transcribed to viral DNA. So this is reverse transcription. When it reaches the nucleus of the cell, this particle, known as the capsid, breaks down, uncoats, and releases the viral RNA into the cytoplasm of the cell. The viral RNA is then integrated randomly into the host cell genome with the help of a second viral-specific enzyme called HIV integrase. At the point of integration, the cell is infected for life. We don't have any current tools which could extract viral DNA. The cell may enter a latency phase, which can last up to 6 decades, but at some point, the cell may be activated, viral and host DNA transcribed into viral RNA, which is translated into viral proteins, which are assembled at the surface of the cell and then bud off as new viral particles. The last step in the life cycle is to cleave these viral polyproteins And that's done with a viral specific enzyme called HIV protease. And once that step occurs, the virion or viral particle becomes mature and infectious. So a number of steps in the life cycle of HIV and a number of steps that we can inhibit today with antiviral drugs. So the oldest class of drugs targets reverse transcriptase. These are the reverse transcriptase inhibitors. Two types, nucleosides that look like the DNA bases. So these are nucleoside analogs, or non-nucleoside reverse transcriptase inhibitors that don't look like the DNA bases. The next class of drugs to be approved were the HIV protease inhibitors, targeting that step late in the life cycle. And some of the initial triple combination regimens use combinations of these two original classes of HIV drugs. But progress kept going. We began to have additional types of drugs. The fusion inhibitors inhibit this step where viral and host cell membranes fuse. We have chemokine receptors inhibiting HIV's interaction with that cellular receptor. And more currently, we have CD4 attachment inhibitors, which prevent GP120 from binding to the CD4 receptor, the first step in the life cycle. These three classes of drugs are known as entry inhibitors. And then the next class to be approved were the HIV integrase inhibitors, targeting that enzyme in the middle of the life cycle. And the most recent drug to be approved is the first example of an HIV capsid inhibitor, which not only inhibits the capsid from uncoating, but also inhibits the capsid from reassembling. So here are the 35 drugs, this time listed by mechanistic class. The column on the left are the reverse transcriptase inhibitors, the nucleosides up top, the non-nucleosides on the bottom. In the middle are the HIV protease inhibitors, the biggest class, and the HIV integrase inhibitors. And then on the right are the types of entry inhibitors, fusion, chemokine, and CD4 attachment inhibitors. And then the newest class are the capsid inhibitors. If you did a quick count here, you'll realize this isn't 35 drugs. And in fact, 6 of the antivirals have been discontinued from the market, either due to toxicity or inconvenience. We use combination therapy today to treat HIV. This was stepwise progress from the 1980s when the first antiviral was approved, AZT. It was tried in people. What we're looking at here is change in viral load level, and that's on the log scale. So you see about a 90%, almost a 1 log decrease in viral load level with AZT, but a rebound here. And when you look at viruses, you now find AZT resistance. In the mid-1990s, we put 2 nucleoside analogs together that resulted in a more profound drop in virus, over 1.5 logs, but then you had a rebound. And then if you characterize these viruses, some of these were now resistant to both of the drugs that were tried. In the late 1990s, the first triple combinations were used. These most commonly were 2 nucleosides and the new class of HIV protease inhibitors. And what you saw was a decrease in viral load level below 2 logs, but importantly, what you didn't see was a rebound in virus. So what we're doing here is suppressing the virologic activity, viremia, to the point where HIV cannot rebound. And this is 6 months of data here, but we now know that goes out to decades of data. So we can effectively suppress viremia with combination regimens for decades. Question 3, which class of ART is recommended for initial HIV treatment for most patients? Is it an all nucleoside analog regimen, a non-nucleoside or NNRTI-based regimen, a protease inhibitor or PI-based regimen, an integrase inhibitor, INSTI-based regimen, or an entry inhibitor-based regimen? And the answer is integrase inhibitors. So this is the class of drugs that's recommended most commonly to anchor the combination regimen. Why is that? They are potent, well tolerated, and convenient. And that informs current guidelines. You can see these are the DHHS guidelines for what to start, recommended regimens, and all of the recommended regimens are combinations of one or two nucleoside analogs with the anchor drug, the integrase inhibitor. And if you scan down the list, you can see only two of the integrase inhibitors are recommended as initial therapy, either bictegravir or dolutegravir. And in each case, it's with one or two nucleosides. The top three, two nucleoside analogs. The bottom is a novel two-drug combination of dolutegravir 3-TC. So any of these regimens recommended first line. Alternative regimens are some of the other classes we mentioned. So non-nucleoside or NNRTI-based, protease inhibitor-based, and some of the other integrase inhibitors aside from bictegravir and dolutegravir. One pill, once a day regimens have become popular in HIV. The first one was developed in 2006, two nucleosides with the NNRTI efavirenz, and that became so popular both with patients and providers that, as you can see, really we have a fleet of one pill once a day regimens. And these can include anchor drugs with integrase inhibitors or even protease inhibitors. And then, as mentioned, some two-drug combinations have also been proven in clinical trials. So many people today can take one pill once a day therapy. Well, that was a huge innovation and has led to excellent virologic responses. But not everyone succeeds on one pill once a day. And so new approaches continue to be developed. One that's been now around long enough to show up on boards is cabotegravir. So this is an integrase inhibitor similar to dolutegravir. It's potent in an oral form, but the innovation is a nanotechnology formulation, which leads it to be an injectable antiretroviral. Phase 3 studies of an all-injectable regimen of IM cabotegravir or CAB, together with the NNRTI, also injectable rilpivirine, as a treatment switch strategy in people who were suppressed virologically on oral regimens, showed non-inferiority of the all-injectable regimen. And this was published fairly recently in the New England Journal. This led to FDA approval of the all-injectable regimen of CAB rilpivirine. Monthly was the initial FDA approval for switch treatment in people who were suppressed. But the FDA approval specifically says it's for patients who are undetectable on oral ART without a history of virologic failure or drug resistance or chronic hepatitis B, because neither of these agents has activity against hepatitis B. Well, monthly injections were a tall order. They amended the FDA label the next year to allow, based on clinical trials, for every other month dosing and an optional lead-in dosing with oral formulations of cabotegravir and rilpivirine. So this is now being implemented, but there are logistical challenges to the all-injectable regimen, which requires buttock administrations of these drugs. And the biggest logistical challenge is simply the every 2-month injections and keeping appointments and keeping people in follow-up. So this has been challenging. Well, how are we doing overall? Here's some recent data from a US government website, www.hiv.gov. It's estimated in the US right now, of everyone living with HIV, which is about 1.1 million people, close to 90% have now been diagnosed. Of them, about 81% have been linked to care, and 66% have received care. Only 50% retained in care, and then overall retained in care and on antivirals, just under 60% are virologically suppressed. So this points out some gaps in the HIV care continuum that need to be focused on. HIV-related deaths have declined. I showed you that in an earlier figure, and here's some more recent data from the MMWR looking at total HIV-related deaths as shown for you here from 2010 to 2018. So recent data, and you can see a nice decline there. And then when you break them apart, it turns out it's HIV-related deaths in the small dotted line that are accounting for most of this decline. Non-HIV related deaths, which in most cases are other common causes of death in everyone, including heart disease, cancer, accidents, you can see that's been relatively stable. So it's the HIV related deaths that continue to decline. And what that has done, and it's significant, is led to increased life expectancy for people living with HIV who take antiretroviral therapy. What you see here is cohort data. Their goal was to estimate life expectancy for people living with HIV on ART, antiretroviral therapy, for at least a year after 2015, so modern data, at age 40 in developed countries in North America and Europe. And they combined two big cohort studies with over 200,000 people. And over the time period they studied, it was over 5,700 deaths. And so again, what we're looking at is at age 40, how many additional years will you live? Women are on the left, men were on the right. You can see in the general population, a 40-year-old woman can expect to live an additional 46 years, so into her mid-80s. And then if you break down the HIV groups, you can see heterosexuals after 2015, women, the life expectancy is now close to that of people without HIV. And in orange are injection drug users. You can see significant gains there as well, not quite as good as the heterosexual women. And then when you look at men, we're looking at MSM, men who have sex with men, in the navy blue here. And after 2015, you can see they are nearly right next to men without HIV, who can expect at age 40 to live an additional 41 years. Heterosexual men, injection drug users, also showing increases in life expectancy, not quite as good as the MSM. So altogether, all groups achieving increased life expectancy that is close to or nearly overlapping the general population. And what a powerful message that is for our people with HIV. Turning lastly to prevention, great strides have been made recently. We've always had the tools for HIV prevention, the ABC approach: abstain from sex, be faithful to your HIV negative partner, and use condoms, counseling, and testing. This has worked for many people, but of course not everyone. Additional strategies have been studied and many are now proven. So male circumcision, removing the foreskin, which has a lot of CD4 positive lymphocytes, was proven in 3 different African studies to reduce the risk of HIV acquisition by about 40% or more, and that has been rolled out as a strategy. Diaphragms for women often impregnated with antiretrovirals did not work and have been abandoned. The biggest strategy is really using antiretrovirals not only for treatment, but specifically for prevention. And that has been proven in many different studies, both pre-exposure prophylaxis, that's PrEP, and post-exposure prophylaxis, that's PEP. And that's worked both in people at risk for HIV from sexual exposure and from injection drug use. Female-controlled microbicides, so substances a woman could use intravaginally, often with antiretrovirals inside them, questionable. Some studies have shown an effect, others have not. And then the rest of the alphabet, not so good. So decreasing sexually transmitted diseases in the genital tract, you'd think would decrease the risk of HIV. That's been inconsistent. Suppressing herpes has not been effective in reducing HIV. And then HIV vaccines, a whole handful of major studies have failed to show a benefit from HIV vaccines One isolated study in Thailand showed a modest benefit, and additional research in that area. Question 4, which PrEP, pre-exposure prophylaxis regimen, is FDA approved for at-risk men and women? Is it daily tenofovir disoproxil fumarate, TDF, emtricitabine, also known as FTC? Is it B, daily tenofovir alafenamide, TAF, with FTC? C, on-demand TDF FTC? D, on-demand TAF FTC? Or E, all of the above? And the answer is only daily TDF FTC is FDA approved for both at-risk men and at-risk women. The second choice, TAF FTC, is approved for men, but not for women. The on-demand regimens have not received FDA approval for men or women. So what is PrEP, pre-exposure prophylaxis? It's the strategy of administering HIV medications to uninfected but at-risk individuals. And obviously, if a drug that you're using for prevention should be potent, safe, tolerable, and convenient. And the first one studied was a single pill co-formulation of tenofovir and FTC. There are potential concerns. We use these two nucleoside analogs widely for treatment, and if resistance became commonplace because of its use as prevention, that would be of concern. The TDF formulation has toxicities, both renal and bone, and of course, there's the cost of these agents. Nevertheless, randomized clinical trials led to formal FDA approval. We've now had PrEP over 10 years. So back in 2012, FDA approved TDF FTC, one pill once a day, as PrEP for both men and women. And then 7 years later, in 2019, the FDA approved the other formulation of tenofovir, TAF, which reportedly has less renal and bone toxicity for PrEP for men only. Studies in women are in progress and expected. And then the most recent innovation in PrEP approved was using the injectable integrase inhibitor cabotegravir every other month for PrEP. And studies both in men and women showed that CAB was not only non-inferior to a tenofovir FTC strategy, but actually superior, reminding us that adherence is critical for the success of PrEP. So all three of these options are available today. The on-demand approach, meaning taking 2 pills prior to sex, 1 pill within 24 hours after, and a second pill within another 24 hours after, has been studied and shown to be as good as daily PrEP, but has not yet received FDA approval. Here's some of the recent PrEP studies. PROUD and IPERGAY, done in the UK, France, and Canada in HIV negative men who have sex with men, tested PrEP versus placebo or delay of PrEP, and showed PrEP was associated with an 86% reduction in the risk of HIV. And these are the two more recent cabotegravir studies. 083 was done in over 4,500 men who have sex with men and transgender women. 084 was done in over 3,200 HIV negative women in sub-Saharan Africa. And they compared 2 PrEP regimens, either TDF FTC daily, the standard of care, or CAB injections every other month. And these studies were parallel design. In both studies, as mentioned, CAB was not only non-inferior to TDF FTC, but was superior, leading to FDA approval. Unfortunately, continued disparities remain with PrEP. It's not reaching the people potentially who need it. You'll recall that I emphasized that Blacks and Latinos are overrepresented in terms of new cases of HIV in the United States. But what you see here is who's actually getting PrEP, who was prescribed PrEP. Whites, about 78% of those eligible for PrEP were receiving it. However, much different numbers in Blacks and Latinos. Only 11 to 21% had received a prescription for PrEP. So we clearly need to do better with regard to that. There is now a federal plan to end AIDS. Actually, it's been around since 2019. Eliminate AIDS in the US by 2030. How would we do that? Diagnose everyone with HIV, treat them as rapidly and effectively as possible, protect people, that is, prevent HIV using strategies including PrEP, respond to clusters, and make sure that we have the healthcare force to reduce HIV infections and treat it. And the overall goal is a 75% reduction in new infections within 5 years and a 90% reduction in 10 years. Ambitious goals. You can see the cornerstone is to treat everyone with HIV and to prevent HIV with PrEP in people at risk. Lastly, can we cure HIV? Well, you're well aware that there was a well-publicized single case of this. A man living with HIV from San Francisco, living in Berlin, who developed AML and required a bone marrow transplant. And when he received chemotherapy and total body irradiation, needed to go off his antivirals. You can see a rebound in the viral load here and a corresponding decline in his CD4 count, underwent a stem cell transplant from a donor missing the gene that codes for the chemokine receptor, which, as mentioned earlier, is necessary for HIV infection. He rejected his first bone marrow, underwent a second bone marrow transplant, again from a donor missing that critical gene. And afterwards, when the dust had settled, when he recovered, the viral load remained suppressed and the CD4 cells went back up to normal levels. They did multiple assessments, biopsies of tissue, and could not detect DNA of HIV anywhere in this man. And so he was considered to be cured of HIV. He continued to be followed for almost a decade afterwards and continued to be HIV free. This is his photo. His name was Timothy Ray Brown. Unfortunately, his AML recurred and he died of his cancer rather than HIV. Well, this approach has now been replicated in an additional 4 patients. Number 3 here is actually at my institution here in New York City, the first woman to be cured of HIV. Will we be rolling this out as a strategy? No, of course. Chemotherapy, bone marrow transplant, et cetera, has a high mortality rate. So this is not being offered, but did regenerate the HIV cure research agenda, which is in progress. All right, what conclusions can we make today in 2024? As you know, HIV is a worldwide pandemic. Today, routine HIV testing should be offered to all patients at least once in their lives. ART decreases viral load levels, increases CD4 cell counts, prevents disease, and prolongs healthy survival. Current ART consists of 2 or 3 drug therapy and is available worldwide. And the current life expectancy for someone living with HIV on treatment is now approaching that of the general population. And in cases where ART is started early in disease now is the same as the general population. Prevention continues to be key, but needs to be offered to more people, and cure research is in progress. I will stop and hope you enjoyed this tour of HIV 2024. Thanks.